So our second presenter is Dr. Ajay KRISHNAMURThy. A challenge in diagnosis and management, 3 cases of rare sinonasal malignancies.
Yeah, good afternoon, everybody. I thank you for the opportunity. I'd like to present 3 cases of rare sinonasal malignancies that we came across in our practice. Why am I presenting this? Because they are very rare and aggressive because of their difficult to reach locations and rapid progression of the disease. So the first case that I'd like to talk about is a sinonasal undifferentiated carcinoma. Here we came across a 58-year-old male patient who had progressively increasing swelling and blurring of vision in the right eye for about 3 months. On examination, his visual acuity was low, about 618, proptosis, palpable mass in the orbit, which was in the superior nasal and restriction of movements. On imaging, we found a soft tissue mass which was in the superior nasal orbit, which eroding into the ethmoid and the frontal sinus, but not extending intracranially. So we did an endonasal biopsy, and on biopsy, on low power magnification, we found tumor cells in sheaths, nests, and lobules, and on high power, it showed large nucleus tumor cells with scanty neoplasm and brisk mitosis. On immunohistochemistry, pancytokeratin, AE1 and AE3 were positive, and also the CK7 was positive. So it was considered as SNUC, and he was subjected to right eye excision biopsy of the orbit. We did a Lynch incision. We did a Lynch incision just medial to the middle canthus, and also endoscopic approach was utilized, and the tumor was completely resected. At the end of 1 year, there was no recurrence post chemo and radiotherapy. What are the key things? Since it's an aggressive disease and sometimes extension intracranially, then it becomes non-resectable and it will be subjected only to radio and chemotherapy. And whenever we remove it, complete removal is the key to its eradication. The second case I'd like to discuss is about a maxillary alveolar rhabdomyosarcoma. This was a 38-year-old female who presented with us with nasal stuffiness and diplopia on down gaze. On imaging, there was a soft tissue mass which was occupying the entire maxilla, right nasal cavity, as well as the ethmoid, anterior and the posterior ethmoid sinus, and which was impinging from the floor of the orbit. And she also underwent endoscopic biopsy, where there were sheets of small round blue cells were noted, and she was having myogen positivity as well as Desmond cytoplasmic positivity. So thereby reducing it to be an alveolar rhabdomyosarcoma. She underwent a right excision biopsy. We did a transconjunctival orbitotomy, floor, as well as the endoscopic approach. In the intraoperative frozen section analysis, when we did a frozen section, it came out to be negative for malignancy, which is very surprising when the tumor of such magnitude is present. That is because of the heterogeneity of the rhabdomyosarcoma. Unless the entire tumor is examined, we can come across these non-conformational or sometimes negative for malignancy things. She underwent radiotherapy, and she's yet to come for follow-up at 6 months' time. So key points in this is, yes, we usually see it in younger age group where alveolar is much more common, whereas when we see younger adults, children come with embryonal type, whereas the younger adults will have an alveolar type carcinoma. The last case is a lacrimal sac squamous cell carcinoma. A 52-year-old male presented with excessive watering in the right eye, and on examination he had a palpable mass at the medial canthus. Well, on endoscopic examination he had a mass in the right nasal cavity. We did imaging. We found a soft tissue which was in the lacrimal sac, expanding the bony volume as well as encroaching into the orbit, extending up to the optic nerve. And on endoscopic biopsy, histopathological section, we visualized a residual lacrimal duct with SCC growing with desmosomes around it. So the key point would be less than 15% of such cases are actually diagnosed in the first 2 months. Most of them are missed and undergo repeated DCRs and DCTs till the surgery, the diagnosis is confirmed. Thank you.
Your third case is sinonasal malignancy, or primarily it is a lacrimal sac malignancy. So it is now, I think, This is not a sinonasal malignancy, or the malignancy which is rising from the neighboring structure and leading to the secondary orbital malignancy.
Yes, I agree with you, sir. I agree with
That's
you.
why your two cases are the sinonasal malignancy, but third one is the lacrimal sac malignancy.
Yes, sir, I admit.